when a competitor comes off of a cycle, they have two options. They can either do a PCT, which is a post-cycle therapy, which is meant to restore HPT axis signaling to get the testes to produce testosterone naturally, or they can do testosterone optimization therapy. That is the indefinite supplementation of hormones exogenously to maintain homeostatic levels. This is testosterone optimization with needles. This is part 3 of the 3-part series. So I just want to give you guys a little bit of a refresher as to, what those last 2 parts were so that we can kind of see how they all play into the kind of like what we're going to talk about today. And it's just going to be a quick summary. I'm not going to take too much time with them, but the part 1 was simply the problem. And it was just in order to solve an issue, we need to acknowledge that an issue exists. And the whole presentation was based around, just allowing us to present evidence and research that there is hormonal imbalances led by both lifestyle and environmental factors that contribute to infertility and decreased well-being amongst millions of men and women worldwide. So like that was the key thesis of that presentation right there. And what did we talk about there? Well, we talked about testosterone. We talked about its biology, its kind of importance in males and females throughout development, different stages of life. We also noted how testosterone has decreased by 50%, like baseline testosterone has decreased by 50% in Western nations since the 1960s. So 50% is a drastic, and it's continues to decrease year by year. And then we talked about hypogonadism, which is the actual condition of low testosterone, and there's the difference between primary and secondary. So HPT axis, hypothalamus, pituitary, testicular. If we were kind of like a little bit of a refresher, that's just kind of how the signaling for testosterone to make testosterone works. Primary means that there's an interference at the testicular level. So there's like, if you got kicked in the balls and like one of your balls bursted, you have primary hypogonadism. If you kind of have like a metabolic condition like obesity, that is more associated with secondary hypogonadism, and that's like a problem at the hypothalamus or pituitary axis, like at the brain, we can say that. So that's the difference there between them. We'll talk more about the secondary hypogonadism in today's episode or in today's presentation. But we talked about how this also affects millions of men, and it goes very undiagnosed and untreated because of the negative stigma around pharmacological agents and exogenous hormone. Then the kind of presentation went into fertility and how this is an issue in of itself. So oligosperma and azoosperma, low sperm and no sperm are related to body composition and decreased testosterone levels. So how this plays in with decreased birth rates, and how in order to have a sustainable economy and sustainable society, we need to have a base birth rate. And some nations don't even meet that baseline, and they're now facing a crisis. And this is something that more or less most industrialized nations are going to have to face. So it's definitely something to be concerned about, but we don't really think about things that are going to happen in 20 years. We more or less can't even acknowledge the problems that are like right in front of us. So as a society, so this is just me trying to do my due diligence and saying, hey, just in case we have forgot about this might come up later. And then we talked about also women's reproductive health and how obesity, PCOS, and platelet syndrome all are all lifestyle and environmental factors that affect reproductive health. So it's not just men that are affected, it's women as well. So that was part 1. Then part 2 was the solution. And that was testosterone optimization therapy is a multifaceted approach to address low testosterone through lifestyle and pharmacological intervention. And this presentation was just focused on the without needles. So testosterone optimization therapy is Testosterone optimization therapy is different than testosterone replacement therapy. Testosterone optimization therapy has lifestyle attributes that are directly related to it. It's not just a band-aid term to say, hey, you have low testosterone, here, have some exogenous hormone. It's lifestyle things that we do to ameliorate the condition and improve it. So what did we talk about? We talked about testosterone inhibitors. So the things that decrease testosterone, what we can use, what we can do from a lifestyle component to decrease the effect of these. And the main one was estrogen dominance. So estrogen is the hormone that comes after testosterone. So testosterone aromatizes into estrogen. We talked about how excess aromatization from excess body fat leads to low levels of testosterone. The body senses too much estrogen. So what does it do? It has to decrease estrogen. How does it decrease estrogen? By decreasing everything that came before it, testosterone. Then we talked about improper liver detoxification, because the liver is what detoxifies and processes liver out of the body. So if the liver isn't working well, that means that we can't get this estrogen out of the body. The body senses high estrogen, back to what we were previously at, low testosterone. And then gut dysbiosis, how this causes inflammation, and inflammation causes could also lead to improper liver detoxification, because a high inflammatory state for the body systemically doesn't allow organs to function optimally, once again leading to estrogen dominance. Here we talked about all the effects. We talked about alcohol consumption as well here, and how that also plays a role with estrogen. Then we moved into testosterone agonists, like the things that we can do within lifestyle to improve testosterone levels. And we're all kind of familiar with these, but it's nice to kind of just hear them and know that what the research says in terms of them. We talked about, well, we first separated into the three categories, which are the nutrition, the training, and the recovery. In terms of nutrition, we talked about insulin management. That was just making sure that we are in a insulin sensitive state. Just allows us to process energy more effectively towards lean tissue rather than fat. So decreasing fat allows us to decrease the aromatization of testosterone, so less estrogen. And then we talked about organic meats. You are what you eat has eaten. So just getting a good balance of just the types of meat that we eat can lead to improvements in the overall state of the body. So decreased inflammation, because there is a good ratio of omega-3s to omega-6. Omega-3 is the anti-inflammatory polyunsaturated fat. Omega-6 is the inflammatory one. So it tends to cause inflammation. So just having a good balance of this and how this plays into, making sure that the body is working well. And then less processed foods. We talked about what their effect was there with the gut biome, and how this causes dysbiosis, and how that dysbiosis can play a role in estrogen dominance. Then we went to training, how resistance training increases testosterone, how proper energetics, the use of aerobic and anaerobic exercise in order to have proper energetics to be an efficient running human being. And then how daily activity, steps, something as simple as steps, is correlated to testosterone levels. We noted how, people that don't even get 3,000 steps, the vast majority of people that don't get 3,000 steps also have high incidences of low testosterone. That is not to say that steps, just getting to 10,000 steps is going to increase your testosterone, but it's to say that activity, how up and about we are, determines how healthy and how optimally functioning we are. So just starting with simply getting up and getting those 10,000 steps is a step in the right direction. And then the last part here was recovery, sleep, stress management, and supplementation. We talked about how sleep, like 1 week of sleep deprivation, that's like getting less than 5 hours, decreased testosterone by 10 to 15% in just 1 week of sleep deprivation. We also talked about stress management with cortisol. So cortisol is a stress hormone that's released every time we're in a stress kind of mode, whether that be from like emotional stress or physical stress. We talked about how that's like a double whammy against testosterone. So it decreases testosterone and it also decreases sex hormone binding globulin, so that estrogen is more free to interact with tissue because it's not bound to that sex hormone binding globulin. And then supplementation, just things that we can consume to improve testosterone, and noting how, that's not the priority, but it can help, but everything else before it is equally as important. So this is part 3. This is pharmacological agents and how exogenous hormones and other pharmacological agents can ameliorate greater endocrine health issues, and if used properly, side effects can be evaded. So let's just kind of start this. So I want to first note kind of why this is prevalent, to who it might be most prevalent to. And this is for those that are like competitors, or those that are seeking to be bodybuilding competitors. And I'm just going to kind of use it in that context because it's easier to kind of explain what the options are based on that. But just know that everything we're going to talk about also relates to people that have metabolic conditions, people that have obesity, people that have hypogonadism because of obesity or insulin resistance or impaired glucose tolerance. So when a competitor comes off of a cycle, they have two options. They can either do a PCT, which is a post-cycle therapy, which is meant to restore HPT axis signaling to get the testes to produce testosterone naturally, or they can do testosterone optimization therapy. That is the indefinite supplementation of hormones exogenously to maintain homeostatic levels. So when a competitor is kind of like gearing up for a show or a growth phase or anything like that, if they so choose, they'll use anabolic androgenic steroids to improve their physique. And when this happens, there's going to be a negative suppression. So the body's going to sense, hey, I already have testosterone. That means I don't have to produce testosterone. So it's going to shut its production. It's kind of like HPT part of the production down. So then you're kind of reliant upon the exogenous hormone. So once you get to that point, then you're like, well, the show's over, or like my competitive career is over. Like, I just kind of want to focus on other things in life. What are my options? Well, these are your two options. 1, post-cycle therapy. 2, testosterone optimization therapy. Do we get the difference between those right there? Perfect. All right. So let's start with post-cycle therapy. So as we already stated, the goal is to restore HPT axis signaling to get the testes to produce testosterone naturally. So what kind of pharmacological agents can we expect to use, or can we familiarize with ourselves within this therapy? There's clomiphene citrate, which is a SERM. It's a selective estrogen receptor modulator. So how it works is it binds to it's an anti-estrogen at the hypothalamus and pituitary level. So it binds to the estrogen receptors so that the estrogen can't bind to it. So I noted how when in an environment of excess aromatization, we have a lot of estrogen, and that estrogen binds to the estrogen receptors, downregulating testosterone. So this does the opposite. So it binds to it so that the body's like, hey, I don't have any estrogen, like I don't have any hormones, like I need to produce hormones. So then it kickstarts that, like, hey, we need to start producing hormones. So it releases gonadotropin releasing hormone, which then signals the pituitary, the H hypothalamus releases gonadotropin releasing hormone. The pituitary releases LH and FSH, luteinizing hormone, follicle stimulating hormone. That gets to the testes, and then that produces testosterone. So then we have HCG, which is basically that LH monologue. It's just really identical to that LH. HMG, which is identical to both the LH and the FSH, and then aromatase inhibitors, which just decrease estrogen itself. So these are all kind of pharmacological agents that can be used. There's a variety of different treatments, and it all depends on like what condition you have, the duration of your cycle, what other underlying things there are. Because like this isn't specifically, well, let's just kind of go into the applications so I can kind of talk a little bit more about them. But what are the possible applications? Well, first, we already talked about how it could be used post-cycle for a competitor or just somebody that maybe didn't compete, but they kind of fucked around early on in their youth and were like, hey, I'm going to experiment with steroids, and now they don't know what to do. So this depends on the duration, and the duration and intensity of the therapy depends on the response and the exposure to AASs. So some people are just naturally are going to respond better to a post-cycle therapy. Like some people can restore the normal HPT function within 3-4 months. And they could have had high exposure to anabolic steroids during that time. Some people, it takes longer. That's just specific to the person. That just has to do with your genetics and then exposure as well. So the more exposed you were for period wise and also dosage wise, the harder it is to restore this. So there is really no like one answer fits all for the duration of therapy or like what pharmacological agents are used. There's different methods, different dosages. It just depends on the person's response. And some people respond better to using some as opposed to a combination of others. But I can explain the literature as terms of like what it's noted, but it varied with the methods. But we also don't need to get into that. That's just a little bit too much for today's topic. Then that's the first case in which it could have an application. But then the second case is those hypogonadotropic hypogonadism or secondary hypogonadism. So that's those people that have metabolic conditions like obesity, like type 2 diabetes, impaired glucose tolerance, that have low testosterone. Like post-cycle therapy can be used to restart their testosterone production as well. So it's not just for competitors, it's also for people that have conditions that lead to hypogonadism. So PCT with clomiphene citrate, just testosterone itself, HCG, and or AIs have all been shown to increase testosterone levels in those with these metabolic conditions. And they've been used in different research articles pointed to different kind of mixes of compounds. Some just had clomiphene citrate, some had clomiphene citrate and clomiphene citrate and an AI. But basically they all kind of had an effect on. Then the second one that we talked about was the testosterone optimization therapy. That's when you're like, hey, I don't want to do a PCT. I want to just introduce these hormones exogenously and supplement them as I need for an indefinite period of time. Like this is the person that has to be okay with administering their hormone. And there's different ways of administering them. That kind of like, let's go into those. Those are the pharmacological agents. So as you guys might already know a little bit, the main or the most common form is intramuscular injections. That's when you inject an oil-based testosterone. And then there's different esters for these, and the esters are differentiated based on their half-life. So the longer the half-life, the less frequently you have to inject. The shorter the half-life, the more frequently you have to inject because the hormone kind of like denatures itself and it becomes unavailable to use. So the most common ones, testosterone enanthate, cypionate, propionate. That's as far as we'll get with that discussion. Then there's transdermal gels and creams. So you actually can just apply it to your skin and then it's going to kind of seep through and be absorbed. That examples of that are androgel and testim. And then we have pellets, which are actually like surgically introduced into your body and they slowly release testosterone. This is done once every like 5 months, 6 months. And then orals, just like capsules. So transdermal gels and creams, they work. However, if somebody, like, say for example, a woman or a child came, hugged you, and they made contact with the skin after administration, guess what? You just gave hormones to that person. So like that's why that's not really a really viable means of getting testosterone for a lot of people. It's very inconvenient, especially if you're like sweating a lot. Just doesn't give you stable levels. The pellets also, it's like it's very intrusive to have to like surgically introduce these pellets. And if you have to like adjust the dosing, because you also have to put your body into like a range where it feels comfortable. And if you went above or below that range, you have to surgically go back again to add or take off pellets, and that's just too much. And then there's orals, which are they're just newly FDA approved. The research, I have to do a little bit more research on that, so I don't want to talk too much into the oral aspect, but I know that there are two recently FDA approved orals. And all I know about them is that they circumvent the liver. So one of the reasons why orals aren't oral steroids weren't really effective is because the liver broke up the molecule, so it became you couldn't use it. The liver just kind of processed it before it could go into the system. The orals kind of go through the lymphatic system. As I said, that's as much as I know there, but I will research that. You best believe that. And then the application here. So when would you use testosterone optimization therapy over a PCT? So if you're a competitor, this allows you for constant management of hormones while maintaining tissue. So if you are a current competitor and you're like, hey, I'm still in this sport. I'm still like, I'm at nationals and I'm still young and I'm still healthy. I want to keep pushing and I want to see how far I can take it in this sport. Guess what? You might want to opt for testosterone optimization therapy, because this is the best way to make sure that you maintain that tissue and that you have proper regulation of your hormones, because you are basically the governor of your hormone. You're introducing these at your own kind of control of. You're not reliant upon the body to produce them. Plus, that period of PCT, it's not really fun for most people, just because your hormones are all wonky for a certain period of time. And it doesn't make sense to kind of go back into that place every year that you do a cycle. It's just better to just get on TRT, blast again, get on TRT, blast again, rather than PCT, take two steps back and then try to take one step forward. And then we also talked about how this can also improve those conditions with hypogonadotropic hypogonadism and secondary hypogonadism. TRT was one of the along with clomiphene citrate, was one of the means by which we were able to increase and restore testosterone levels. So just know that also within all of these conditions, obesity, testosterone type 2 diabetes, impaired glucose tolerance, they were all ameliorated just by the introduction of testosterone, by the increase of testosterone. So like no other lifestyle factors changed except for that. That is not to say the strategy that we should implement in these cases, but it is to show that testosterone can improve somebody's body composition, their lipid metabolism. Oh, okay. So before I hop on to the next one, do we have any questions on this so far? Anything that seemed interesting that you want a little bit more info of, or have I lost all of you guys?
Maybe
Now
a little because it is a lot to
yeah.
like fully
Okay,
understand.
so what give me something that you want a little bit more of a discussion on or clarification.
I don't even know where to start. I guess for me, it's more so like understanding just everything in general. Especially since I'm a female, this is just like
Yeah, no,
hopefully,
this is more geared towards the male
yeah.
competitor. But there are things, these are considerations for a female competitor as well, but doesn't the female competitor, when faced with this road, that's a completely different thing. Like anabolic steroids are probably androgenic steroids are something that is second option. There are other
Hmm.
kind of pharmacological agents that are preferred too for females, specifically because of the androgenic side effects. And we're going to talk about those androgenic side effects actually in the next part. So that's I'll try to kind of relate that back to this topic while we're going through it. So the next one was side effects. So like what can we expect from testosterone optimization or like from the introduction of testosterone exogenous hormones? Like what happens to the body or does nothing not happen except for just increased testosterone? Well, in terms of internal health, um, these are like the main concerns that people have. And I'm going to note how these aren't really the research hasn't really proven that they have a negative detriment. In most cases, they actually benefit some of these health markers. So let's start with hematocrit and hemoglobin. So that is basically hematocrit is the ratio of red blood cells to fluid or it's kind of like the ratio of blood cells or kind of like solid particulates in the blood to plasma. So if you have a high hematocrit, that means you have like a lot of solid, not a lot of liquid, which means that you have high viscosity. So we have thick blood. That's not really good because that increases blood pressure. And that's a lot of like force pushing on the arteries. And that we don't want that because if there's a lot of that, then like creates little kinks, like little cracks, and then plaque can come in there and like start building up. And we kind of already know what happens when we do that. That's increased. That's what puts us at increased risk of cardiovascular disease. So hematocrit, and then hemoglobin is how big the red blood cells are. So if they have more hemoglobin, that means like a protein that actually binds to the oxygen. If it has more of that, the cell becomes bigger. So if the cell becomes bigger, it kind of leads to higher hematocrit by that because the cells themselves have a bigger volume. So kind of like that was the main argument. And that's what a lot of people see. That's when using testosterone. Like we notice that these things go up. And that's for competitors, people that are in super physiological levels. Super physiological just means outside of the normal ranges. So normal ranges for men are about 350 to 900 nanograms per deciliter. That's normal according to like labs. If you go above this, that's super physiological, and that's usually where most competitors go for those blasting periods that they're on. So that that is true in those conditions. However, with TRT, it's not very much different than somebody that has high hematocrit and high hemoglobin because of high altitude acclimation. So somebody that's on TRT and then somebody that lives in Denver, Colorado, they have the same hematocrit hemoglobin levels. Like you wouldn't be concerned for that person in Denver. Why are you concerned for that person on testosterone? It's like it's the same thing. And then phlebotomy, which is just the withdrawing of blood. So you can also use that if you're really concerned about it. Then in terms of the liver, there's no significant risk of hepatotoxicity at replacement dosages. So we're talking about like TOT, like we're not talking about competitors in a blast cycle. We're just talking about people that want to make sure that that their endocrine function is optimally running, especially into old age. So this whole presentation, I should have probably started with like, we don't have to worry about this, but we're going to have to kind of think about this when we're 35, 40, 45. And the way things are going, usually doctors, this just comes from like what I noted a doctor to have said in one of the texts that I was reading, but they had a rule that you couldn't be prescribed testosterone under the age of 40. But they've gotten rid of that rule because so many young people under 40 have now come to them with actual diagnosis for hypogonadism. And that in of itself just points that the general trajectory of things are like, hey, like this is getting worse because of these lifestyle and environmental factors. And if for our generation, it's only a concern at 30. For the next generation, it's going to be or 40, it's going to be a concern for the next generation at the age of 30. And then how far are we going to take this? So that's why we're having this discussion. It's not because of today, it's not because of tomorrow, it's because this is a thing for the next 10, 15, 20 years where we're going to have to kind of like face this reality. And then lipids, kind of like just keep going down the line of kind of what systems have been most notably thought to have been affected by testosterone optimization. Let's just kind of go down the list a little bit more. We have lipids and cardiovascular disease. So testosterone has actually been shown to decrease LDL, which is that bad cholesterol and total cholesterol. So it and higher homeostasis testosterone levels are shown to ameliorate risk of cardiovascular disease. So both of these things, so testosterone actually improved the lipid profile. So having low testosterone is actually worse than having exogenous testosterone introduced to a level that is homeostatic. Then prostate and PSA. So we talk prostate enlargement is a concern for most men, given that this can lead to prostate cancer. This was the research was just overwhelmingly showing that testosterone, having normal levels of testosterone, was better at ameliorating prostate disease than low levels of testosterone. So if prostate cancer is a concern for you, it's actually low testosterone that would be more of concern rather than the introduction of or utilization of TOT or testosterone replacement. Now, let's go into the side effects that are actually related to a little bit that we can relate back to women. And these are the androgenic side effects. These are androgenic side effects can be seen as the things that happen to like the male body or the female body. So virilization is the masculinization of females. And that's what happens when androgens are increased, because androgens are the secondary sexual characteristics of a man. So primary and secondary. Primary sexual characteristics are those that we are born with. It's the things that we have at birth, like our reproductive system. And secondary are the things that develop later on in time. So up until like puberty, men and women are technically like very the same looking. Like I remember people thought I was a girl because I had long hair and I was like really petite. And I was like, no, I'm a boy. It's because I hadn't gone through those secondary sexual characteristics, like the facial hair, the deepening of the voice, the increased muscle mass. Like these are the secondary features. And this is what women have to be cautious of when utilizing anabolic androgenic steroids, is that these things can develop, that deepening of the voice, the facial hair, the kind of like the sharp jaw that kind of looks like man, the enlarged clitoris. So, and kind of hair loss is another one. Hair loss, acne, and then changes to libido, which is basically sexual function. So these are all things that can be affected by super physiological levels of testosterone, and even sometimes in TRT dosages. However, there is things that we can use to ameliorate all of these. So I noted how there are some side effects, but there's other things that we can use to combat these side effects, and these side effects don't outweigh the negative detriment of what having low testosterone could do. So if it's like, if I have to choose between having like balding and being at risk of cardiovascular disease because I have cardiovascular disease, having kind of struggling with obesity or type 2 diabetes because of my low testosterone, I'm like, hey, I can probably do without my hair if it meant that all these other conditions could be ameliorated. And that's what a lot of people are probably going to face later on in the future. So just kind of what happens in terms of males is that we face acne, hair loss, and libido changes. But there's specific things we can use within kind of like off the counter medication to ameliorate this. and it's not much of a problem with replacement dosages. This is more of concern when we're going super physiological. And then the one that is of most concern, though, for men when they are on TRT is infertility. So I noted how when we introduce exogenous hormone, the HPT stops working because it's like, hey, I don't need to work because there's somehow already testosterone in the body. That's also decreasing intratesticular testosterone. So because the testes don't have to produce testosterone, that means that there isn't any testosterone in the testicles themselves. And how do we create sperm? We create sperm with testosterone and with androgen binding protein. So that's what creates sperma. And both of those things are produced in the testicles. So when you have one testosterone, but that's not actually being produced there, that's introduced exogenously and it's going everywhere else but the testicles, eventually we lead to low sperm count. But there are things that we can also use here to ameliorate this. So HCG, clomidophenol citrate, were all used to improve fertility within those people that were still wanting to have kids while being on testosterone optimization. But as I said, this is more for like that later stage on in life. And when we're all probably like 35, 40, we might be okay with not having kids. And actually, testosterone was first studied as a male birth control. So there's that for guys too. And so that would be it on this presentation.